Good day, wherever you may be watching from. I'm Mike McAvoy, the chair of the EMS section for the International Association of Fire Chiefs, and I'd like to welcome you to our webcast today, Three Pondering Points regarding alternative transport destinations. We have a couple of great speakers to share information with you, and hopefully this will be an opportunity to engage folks in conversation. Couple of housekeeping ideas, rules before we begin. We're using voice over IP technology, so make sure that your volume is turned up. All of the audience microphones have been muted. If you have questions, please feel free to put those in the Q&A box, which you will see on your right-hand side, the upper part of the screen. We'll watch both the Q&A box and the chat box. We will have some polls periodically that will pop up on the screen for you to answer. And then for folks who are interested in getting the slides for this presentation, they actually are posted right here under the handouts box next to the chat function and the Q&A function on your screen. So feel free to download the slides, download some of the information provided by our partners at PCG, and any questions that you have as we move along, post those in either the Q&A or the chat box. If you run into a technical question, you can email the webinar's email on the screen here, or use the chat function, and someone will get with you to take care of your technical question. Again, handouts are posted on the right-hand side of the screen under the handout piece. And those also have some information from our partners about the PCG group. So I would like to express our sincere thanks to the Public Consulting Group. This is one of a series. I think this may be the sixth, maybe seventh webinar that they have put together for us, specifically to address needs that have come from you, the members of the EMS section. This one pertains largely to the ET3 program, but I think has some really useful points that you'll discover that are pertinent to any of the upcoming changes that we're going to see in regulations that allow us to use alternative destinations and continue to be paid for some of those transports. So it's been a pleasure to work with the folks from PCG, and I know many of you are familiar with them. So I will, without further ado, introduce our lead presenter, Tim Nowak, and allow him to introduce our co-presenter, Chief Camelli. So Tim.
Thanks, Chief McAvoy. I really appreciate it. So I'm Tim Nowak. I'm a senior project specialist, or essentially a fire and EMS consultant with Public Consulting Group, and remotely here from Wisconsin. And I'm always curious to see where everyone else is from. So if you don't mind, in the chat box, please, you're welcome to send in.
I'm not hearing Tim, so let's troubleshoot that technical difficulty.
Why do we not have me?
Oh,
okay, how about now? How about now?
Yeah, I could hear him, Mike.
Okay. Good. Sorry about that. So, I'm always welcome to, or interested to hear and see where everyone's from. So in the chat box, you're more than welcome to please chime in from where you're from. And of course, any questions that you have, we're going to try to monitor the Q&A box afterwards. So just do a flip over with the tab. So about myself, I've been involved in EMS for coming up on 20 years now. Also involved in the fire service, having had a chance to work throughout the country, primarily in Wisconsin, Minnesota, Colorado, and Florida, and then actually full circle or full triangle back to Wisconsin. I'm working primarily with data analysis on the EMS side, system quality, training and quality assurance, and also having a dabble in the MIH and CP realm. With me, I am very pleased to share, or at least present with Chief Mary Camelli, who's Fire Chief out of Mesa, and I will let her have the mic for a little bit.
Hi, everybody. I know it's morning some places and afternoon in others. It's nice to see you Again, my name is Mary Camilli. I'm the fire chief for the Mesa Fire and Medical Departments. Been here for 38 years and serving as the fire chief for 5. We've been engaged in a variety of different community medicine type programs that I'll be sharing with you today. Nice to see you.
So thanks again, Chief Camilli, and her insight is going to be very valuable and great with this presentation, and certainly sharing the kind of the real life aspect of what Mesa has gone through with respect to alternative transport destinations, and then also some of the ETC program. So I'm going to cut my camera off here so we can just focus on the presentation. And so let's start here. So, we're all used to this. We get dispatched to a scene, we arrive, we do our work, we decide that we are going to then transport or cut the patient loose, sign a refusal, whatever that might be. With the transports, however, up until now, or up until a few months ago, everything has been pretty cut and dry, right? We're used to, we get the patient, load them up in the ambulance, and then we decide that we are going to go to the hospital. So this is what we have been accustomed to, we're used to, the infrastructure's there, we're built for it, the crews are used to it, we know where we're going, or at least for the most part, we know where we're going, we know what hospital to go to. This has been established. And, it works, at least on paper, in theory, in infrastructure and logistics sense, it works. Adding in alternatives, however, changes up the ballgame a little bit. And so this brick and mortar fashion that we are used to may not necessarily be what the future holds, or at least the present holds for some organizations. And that's what we want to look at here. The way that it's always been done is certainly a phrase of contention. And it can be a positive phrase. It can be also a very, very negative, toxic, horrible, crippling phrase. But on that same token, there is that positive sense. And I think we want to dabble in that little positive sense a little bit today. So the way it's always been done might just work because it's just the best thing. So it might just be the best thing going forward for your organization to stick with. It may only be need to be tweaked a little bit. Maybe we just need to do some adjustments to adjust the course a little bit from where we're going to make it a little bit more effective for tomorrow. Or the way it's always been done, quite honestly, might be way off, antiquated, and ineffective, and just needs to be scrapped and re-looked at. So, that's the way it's always been done. That's just one common phrase. But if you've got a reason, and I think that's the best thing to keep in mind, is you've got to have a reason for why are you doing it? If it's the only way or it's the way it's always been done, what is the root reason for doing it that way? And if you don't have a reason, I would suggest coming up with one, or entertain the idea of changing. If it's working because of this and that, great. If it's not working, well, then that's where we need to instill some innovation. And I think that's what ET3 and CMS is trying to get at, is look at some innovative practices. But it may not always work for everyone else. What is established may just, quite honestly, be the best thing. So I'm curious. We've got a poll here for you, and we can pop this up. I'm curious to find what your involvement is with the ET3 program. So I'll give everyone a minute here. Is your fire department or EMS agency participating in the ET3 initiative? Yes, no, never applied, or thought about it but declined for whatever different reasons. Kind of curious. Okay, so seeing a little bit of this here, it looks like a lot of organizations haven't applied, and that's okay. We've got a handful that are involved with it, so good response overall. And I think every organization, every fire department, EMS agency is going to have a slightly different reason for why they chose yes, why they said no, this just wasn't our thing, or really thought about it, got into it, but decided to back out. It just wasn't the best at the time. So every organization is going to have a slightly different reasoning behind those. And I think that as we go through this presentation, we'll uncover some of those reasonings. So, looking at the innovation behind the alternative transport destinations, I think this is where we are conflicted or where we're being pulled or swayed is, some people want this to happen where, again, we're traditionally used to going to the hospital. But, well, what about urgent care clinics? What about PCP offices? What about other facilities or locations, behavioral health centers? Why can't we go somewhere else for the patient? And again, there's a number of reasons for it. And sometimes, quite honestly, what it might just come down to is that at the end of the day, you need this to happen. You need to get your ambulance to the hospital because maybe it's the only resource, or it's the closest resource, or it's got the quickest turnaround, or the other facilities don't have the infrastructure to handle getting a patient directly from you. So even though this whole push toward alternative transport destinations is an innovative, new, great, and sometimes even crazy idea, that's wonderful, but it may not work for you, and that's okay. So that's what I want to try to get at here is that it's okay, but it's okay because you've got certain reasons for that. And I think those are the important things to uncover to be able to explain, especially as an EMS chief or fire chief, is, politicians, community leaders, stakeholders are hearing about this happening. Why aren't you doing this? Is their question to you. And having an answer to that, not just because, but having an answer to that is the key. So, looking at each of these facilities, urgent care centers, PCP offices, behavioral health, dialysis, so forth, what's wrong with them? Why don't they work for your community? Or why don't they work for your ambulance transport service? Again, having that reasoning is the key part of it. Whether it's the staffing, the infrastructure, the physical, drop off the patient part, they're just not nearby, whatever that might be, having an answer, a concrete answer for why they don't work for you is the important part. So as we get into here, we're going to ponder these three different points. Looking at whether transporting patients to an alternate destination is feasible or practical for your ambulance service in your system. So feasibility is one part of that. Whether your community is really set up with the right healthcare infrastructure to handle these alternative destinations. So the infrastructure being part two. And, does this really solve a problem? Or are we just moving the problem to another location? So solving a problem being part number three. So for starters, here's my little disclaimers for the presentation. So I'm not advocating for lights and siren response or transport at 100% of the time. It doesn't have really anything to do with this presentation, but I'm just throwing that out there. So not advocating for that in any situation or in the least. Not advocating for no changes at all to the current system. Not advocating for all EMS agencies to adopt the CP or MIH model. Not advocating for transport-only reimbursement model, nor am I advocating for greater scene times or longer 911 resource time allocation, time on task, or not advocating for breaking away from the emergency part of EMS. These are all important things, and I'm not saying that we need to, stop these things or, stick with the past just because. On the other hand, though, I am advocating for evaluation and understanding of your system. Why does your system do things the way it does? Why is it not going to do this? Why is it going to do this? Advocating certainly for community risk reduction. It's not just a fire service term, it's an EMS term. Advocating for appropriate response in transporting triage. Whether that starts, at the beginning with dispatch, or it's your agency that's doing that, which really we've been doing forever. And I am advocating for improvement and innovation to our 911 services. So let's take a step back. Again, is this a solution in search of a problem? Is there really a need for this within your community? You look at your call volumes, and what is that? What's that impact on your current units? Are the call volumes increasing? Now, granted, 2020 will forever be an asterisk in everyone's data benchmarks and everyone's data platform for call volumes. Either your call volumes skyrocketed or they just plummeted. Very few I've seen at least have just stayed the same. So that's the tricky part of it. But prior to COVID, or even with COVID numbers in place, what do the numbers tell you? What do your call volumes look like? Do you really have a unit hour issue? Do you really have a time on task issue? What are your transport times? And if you're looking to bring patients to an alternative destination, will that cut down transport times? Will that improve overall turnaround times? What do those look like with the ED? And that's a whole another issue of wall times and being stuck with those facilities. But in that context, will bringing your patient to an alternative destination really make a difference? And actually, how many times will you do that? What impact, what percentage of total calls will that be applicable? So, which patients typically are going to fit into this bill? Minor acute injuries or illnesses, acute on chronic ailments or illnesses that are non-emergent, care continuum needs, needing prescription refills, primary care access, behavioral health certainly is a popular one. And Chief Kameli is going to be able to talk very extensively on that. Social services needs, or quite honestly, you don't really know. The patient's got to go somewhere. They just don't need an ER, don't need an emergency department. And you got to bring them somewhere. So an alternative destination just might be the best, or at least the first place to go. So that's oftentimes our population point. And the topic of social determinants of health really has been, one of those areas that has finally popped into our radar. And for the past 5 years, it's been a growing part on our radar. But before that, really was, not of much consideration. So, within every community, everyone is affected by these differently. What is their access to healthcare, or the education and the outreach? Certainly an area that we can directly tackle. The social and community context. What's the population demographic like? Or is it different? What does transportation look like? Living situations, the economy, the stability there, the neighborhood build out, the infrastructure within the community to get to facilities. Are you the only way that people can get to a facility? Or are there other options? So all of these, are playing into this decision-making point that you as a chief have got to consider with, again, why you are or aren't doing the alternative transportation model or considering it for the future. So this is coming straight from CDC. They recognize that public safety, emergency, and health services are a part of this. They are part of the solution, part of the fix, and a part of the problem of social determinants of health and the impact of it. So we, whether we like it or not, are part of the long-term solution. And I think that everyone who's got a chief title or director, executive title within the EMS realm has got to be having some sort of a mindset of how can we address this? How does it pertain to our community and our agency? So again, what is your agency's impact? Will transporting patients to an alternative destination make a difference, or won't it? Will it be such a small population subset or a percentage subset that it's just not worth it to go through it, number-wise, speaking objectively? Or will this make a significant impact? Will it really decrease your time? So will it really decrease or improve your productivity as far as call volumes? So again, looking at it from the objective standpoint, what's the impact? Now, having said that, so I'm from Wisconsin. And I certainly recognize, and again, a big emphasis with this whole presentation is that what works for the system where I'm in Green Bay is going to be entirely different than Milwaukee, Madison. It's going to be different for La Crosse, Eau Claire, Wausau, Winelander, and Superior. Every other place throughout the state, totally different demographics, totally different infrastructure, the availability of resources, it's all going to be different. And I think that's the key, is that this whole concept of alternative transport destinations, of ET3 in general, it may be the saving grace for some agencies, but it may not be for yours because of all these different factors. So again, let's look at some feasibility and practicality aspects of alternative transport destinations. So another poll here for you will pop up with concerns. What is your primary concern for transporting patients to an alternative destination? Give you a few seconds to populate that. All right. So, each one of these different components, again, this may be your why. This may be your reasoning for why you aren't doing it. Now, having said that, these are all concerns or considerations, they're emotions. The important part, and we'll talk about later on too, is the important part here is that emotion aside, you as a chief are responsible for not just the emotions, the effectiveness, but also the objectiveness behind it. So when you're asked about this and why you're not doing this program or why you are pushing for it so much, data is going to have to be your answer. And what will the reality be? If you're fearing that this will lead to an ED transport anyway and a double bill, prove it. What's the impact there? What are you suspecting, and how are you basing that off of? If you're not sure the facilities will have enough staff, talk around. Try to get in contact with facilities ahead of time, so that you can at least say that you've explored this opportunity. You've examined it with 3 different key players in the area, and have determined that this would just not work because of this factor. Logistics aren't there. Or you fear that it would really lead to a longer turnaround time, and projecting off of what that is. So try to provide some concreteness, some objectivity to the subjective world around it. So time on task. Again, hospital turnaround times are certainly an issue. So will integrating in alternative transport destinations solve this? Is it really the right way to approach this issue? There's some other great articles that are out there to talk about wall times and the legality and the EMTALA stuff behind it. We won't go there, but will this help to lessen some of that burden that's put on the hospital system? So times as far as to transport, if you're in a small community but have an urgent care clinic locally or a PCP office, will it make a significant time difference? And that could be a very valuable thing. Will it shave 20 minutes off your transport time just by going to a smaller location? Offload concerns too. I think one of the biggest parts is that if you are going to integrate this, we've got the easy job. We bring the patient there, we do the handoff probably as the same way you would going to an ER, and then we leave. We're done. We're out of there. But if the hospital or if the urgent care clinic, the other facility is not used to that format, they know they have patients coming in because they have appointments. And this is this suddenness. If they're not used to that concept or that practice, how does that work out? Or even, within this fashion, do patients even need to be transported on a cot or even in an ambulance? Maybe a different vehicle of sorts is more appropriate too. So all of these, I think, need to be considered with respect to this. Is an ambulance the right vehicle to accomplish this? Even with respect to level of care, should an ALS ambulance be providing these transports? So if you have this available in your system where you can maybe offload this to a BLS crew, that might be the best bet. I mean, there's no time sensitive nature for this. So why not put your higher acuity resource back into the mix and make this a BLS priority instead? So, transfer of care also can make things kind of awkward for us. We're so used to transferring our care to a nurse or a physician or a mid-level practitioner. But now, what's your comfort level with transferring care to a medical assistant or even just a registration and dropping from there? How does that change up your signature forms and all the dynamics that go along with it? Again, you can imagine all the policies that have to be in place, not just protocols, but policies that have to be in place. The legal considerations, the billing considerations, just do align all this together. And workload, at the end of the day, really, will this make an improvement? Will it make your crew's job easier or harder? Is it going to add prolonged time by going out of their way to go to an alternative location? Or is that hospital simply the closest thing? 5 minutes, not a big deal. But once you start getting into double digits, that has a big impact. 15 minutes added on a trip on the front end, which also means 15 minutes back. So there's a ripple effect that could happen. Or even from their standpoint too, the added stress of trying to figure out where to go. It's one thing that we've got a trauma center or multiple trauma centers. Which stroke center do you go to? But then now we're considering in well, do we go to the ER? Patient maybe wants to go to the ER, but we don't think they need to, or we want to try to convince them to go to an urgent care center, but they really want to go to an ER. So you may have to have this little conflicting battle with the patient on trying to convince them that ER is not the right spot, urgent care center is. So, how do we work this? And does that really just cause more stress? Is that worth it? Looking at the infrastructure side, I think a part of the entire holistic approach to what we do in EMS, or the holistic approach to what we're doing in mobile medicine, is instilling a sense of ownership in what we're doing. So if you've got a mobile integrated healthcare or community paramedic program, I would encourage you to look at your program from kind of this standpoint, having some ownership. And really what we're looking to do with those programs is provide outreach, wellness, and then navigation. And navigation, you can maybe even throw in transportation there too, through this methodology. But at the very least, this is what I think the premise is behind MIH and CP programs: outreach, wellness, and then navigation. And how can you build that in your organization? Or even if you don't have a program like this formally, doesn't mean that you can't adopt somewhat of this holistic approach to it. How can we improve or educate on the front end, provide that community risk reduction, provide that prevention? When we're there, when we're on scene, how can we then inform the patient, promote a well or a better lifestyle or something to improve this incident, prevent it from happening again? And on the back end too, whether it's a release, whether it's transport, how do we get them into the system? How do we get them to the resources, or the resources to them in an appropriate fashion? So another poll question for you. As far as those alternative options, are you optimistic about the options that you have available for you for alternative transport destinations within your area? Let's look at these questions. And I think, as we would all suspect, areas that are more heavily populated, more urban or suburban oriented, are going to have more resources. But just because you have more resources doesn't, again, mean they are the right or the best resources to have. So I can understand, that cautiously optimistic standpoint. So again, logistically, and infrastructure-wise, are your alternative transport destination locations ready? You think about your urgent care centers, and urgent care center, not quite like a freestanding ER, a step below there. Some of them have great resources, but some don't. Well, now you've got to factor in, does this place have imaging? The sprained finger, even the broken finger, the small ortho injuries, smaller, lower acuity, acute on chronic exacerbations of illnesses. Do they have the imaging, the lab structures there to handle the evaluation of these patients? Or is this just going to result in a follow-up trip? Same thing with a PCP office. Behavioral health places, again, too. Is bypassing the ER the best option? Or do they really need to have some sort of evaluation? Is there something else involved where behavioral health is related to this, but it's not the root cause of what's happening right now? It's just a label that is there in existence because of. So, this is all stuff that has to be going through the crew's minds and making these critical and clinical decisions. So what is the plan? Again, there's a lot of work that has to go into this thought process in the front end, but what is the plan? Imagine this. You bring your patient to an urgent care center, and then now you end up having to get, called for a 911 trip to pick up that same patient and bring them to an emergency department for this same problem because the alternative transport destination couldn't handle the patient. What is that image recovery going to look like? What is that impact going to be? Now, will that happen often? Probably not. But when it does happen, it only takes that one time, for bad imagery to happen. What is your plan to combat that? How do you handle this? So are you going to be second billing the patient? What is that overall cost impact to the patient who now is going to incur that second bill? So what's the QA process going to look like on the back end with each of these situations? And hopefully, again, this is stuff that you've got to build into this structure to really focus and hone in to make sure this is successful and feasible. Even with your release and refer patients, is it more feasible to release patients and refer them to an alternative destination? Now, maybe you in the ambulance can't transport them. It's not the best option, but if you're going to release them, then how are they going to get there? Whether it's a family member, public transportation, taxi, ride share, whatever that looks like, a neighbor, how long are you going to wait to help set up that ride? Or do you have a means to provide them, in essence, a courtesy ride? Will a police officer give them a courtesy ride to the location? Can you legally do that in your ambulance? Or how about a separate vehicle, battalion chief car? Let's shuffle it up to the battalion chiefs. Middle management, shuffle it all over there. So will that work? Is it feasible for you to do? So here I'd like to introduce again Chief Camelli and her program that was instituted in Mesa, Arizona. A great example, and we'll have some shining opportunities to share what has happened, what has worked, and kind of how that impact has rolled out. So I'll get the mic to Chief Camelli for that.
Thank you, Tim. Tim has some great questions for all of us as fire chiefs. Does it fit in our community? And I have to say the programs that we did in Mesa, and you asked the why, what you see here is what's going on in the Valley today. Our ER wait times, that's all over the news. And about 9 years ago, and this ebbs and flows. We have periods that they're, busy like this. 9 years ago, it was very consistent that the ERs were just overwhelmed. And it was impacting 911 because our ambulances were backed up at the hospital. At that time, it was Southwest Ambulance in Amar, backed up at the hospital for hours. It was even quoted in the paper one time saying that they could take a patient to San Diego, which is a 6-hour drive, faster than they can be offloaded here in the ERs. And so we had an issue on our hands. We thought, as 911 providers, what can we do to help reduce this, mitigate this problem? What can we do on our end? Since we see the patients first, we knew we had low acuity calls. We knew that many patients we were taking to the ER didn't need to go to the ER, but a lot of them, and it's probably across the country, a lot of people use 911 as their primary care provider. So we started really thinking out of the box. And about 9 years ago, we partnered with Mountain Vista Medical Center for a nurse practitioner. We thought if we can get a nurse practitioner on site, 2 persons we paired a nurse practitioner with a captain paramedic to go on these low acuity type calls that we wouldn't have to transport, and to kind of reduce the number of beds being used in the ER that could really be used for a critical patient. We partnered with a hospital, and we also partnered with a behavioral health facility. It was known as CPR Behavioral Health that provided us crisis counselors. We knew our behavioral health calls were going up. They were increasing. And so we thought, we know that, a suicide threat transporting to the ER is not the best place for this patient. And oftentimes behavioral health patients take up a bed for multiple hours and even days until they can find a place for them. So we had these 2 units, both of these programs in place when we applied for a CMS healthcare grant. It was a $12 million healthcare grant that we had, and we utilized that for 3 years. And I tell you, I feel like there was so much benefit from this program, keeping patients that didn't need to be in the ER, because you take some folks to the ER, now they're exposed to other germs unnecessarily. Kids with little ear infections had to sit in ERs for hours. These nurse practitioners were able to treat them on scene and release them. Another benefit of the program that we didn't even consider was how it helped our police department. That anytime they arrested somebody and they complained of chest pain or difficulty breathing, they can call it the nurse practitioner vehicle. They can medically clear them. We can't do that as paramedics, They medically clear them. PD takes them right to jail. They don't have to transport the patient. They don't have to follow the patient and then go pick the patient up and take them back to jail. So that was a perk we never even considered. During this 3-year time period, we met with multiple insurance companies, and we met multiple times because what we wanted this program to be was sustainable. Once the grant was done, we wanted to make sure we had some funding. The city knew that this was a great program for our community and how it helped the healthcare system as a whole, because it really did. But we thought if it's helping in the funding of, avoiding transports that didn't need to go to the ER, it was saving a lot of healthcare dollars. We thought if we can somehow connect and get some of this funding back to get some reimbursement, that would help us to keep this program going. Everybody loved the program. We met with the love of the program on the insurance side, but when it was all over with, we never got a penny to help run this program. So because of that, the nurse practitioner had to go away. We couldn't continue funding that. But the CPR, behavioral health, we kept the crisis counselors on. We kept them operating all the way until about 2 months ago, when the funding that the crisis team was using ended up going away. So right now we're in the process of getting it back, either through grant dollars, and we're working with some reimbursements that may be coming. So, and I'll get into that. So anyway, this was where we were and where we are today. What would the behavioral health, and the reason I say for us right now is we're getting back to behavioral health first, and then we're going to work towards the nurse practitioner, because this is the patients that are going to the ER. This is 10% of our total calls, of EMS calls. These are the patients oftentimes we take to the ER that take up a bed for multiple hours and days at times. The hospital has to provide a spotter or a sitter, whatever they call them. They call them different things, to make sure the patient doesn't cause harm to themselves or harm to others. So keeping these patients out of the ER is probably what's best for them and best for the healthcare system as a whole. We found out that 50% of the patients that our crisis counselors were evaluating ended up staying home with a safety plan, and them talking to their counselor, whoever their behavioral health provider was, and setting up meetings, things like that. So they didn't even, 50% of the time, they didn't even have to go to a behavioral health facility. We had the community medicine program running for like 9 years, and we want to get it back up and running here very soon. The SUV, and to Tim's point about do they need to be in an ambulance? So for all those years, we used a SUV. Once the field determined it wasn't a medical issue, strictly behavioral, we transported them in. After they did their evaluations on scene, we transported them in the SUV. This was staffed with 2 crisis counselors. As I mentioned, to support law enforcement, not only in that regard with the nurse practitioners, but the behavioral health as well. When they get on the scene of someone that, if there's no danger in terms of weapons or anything like that, they can turn them over to our crisis counselors and the officer when available as well. They do evaluations in the field right there. Why that's beneficial is because when the crisis counselors did evaluations in the field and they communicate with a behavioral health facility, because they're not in a safe place, they're at home, they tend to give them more opportunity to place them in a facility if that's where they need to go. When they're in the ER, the reason it takes longer is because they know they're safe and they're in a safe place, so they don't, there's not the urgency to get them placed somewhere. So transporting to a behavioral facility when needed. And the counselor assessment that they get on scene is the exact same assessment they get when they go to the ER. So when they're in the ER, they get a counselor assessment in the ER to determine whether they go home or whether they need to be placed somewhere else. So that assessment is exactly the same. And then with this program, we were able to connect them. We have social services, and we connect them to our social services. And then they reach out to the community groups that provide services here in our community if that's what they need. So these were all, and now we know that with the ETT program, which we did apply for, we've just asked for an extension based on what just happened with our behavioral health. You do have to transport in an ambulance, and we do have ambulances in our system now. We have about 11 of them. So we could do that in ambulance. Although at this point, when you have a behavioral patient that had just a threat of, let's just use that example, a threat of suicide, we're still using up an ambulance for that transport in order to get reimbursed. But we're willing to do that for the program to make sure it's sustainable. So we tracked all the behavioral calls that we did transport, and we broke up the insurance. As fire departments, we generally never worked with insurance before, but since we started our own ambulance transports and our program that we had with CMS. We started looking at this, and you could see that access, or that's the Medicaid for us, is about 67% of all of the behavioral transports that we have done in the last year. And so ET3 will reimburse for Medicare fee-for-service only. And this is where we ran into some struggle, is because fee-for-service Medicare on our behavioral side was about 1% of the patients. So that by itself would not help us to make the program sustainable. But because of ET3, our access, or our state Medicaid, came on board too, and they came forward and said they also will reimburse for transports to alternate destination or treating and releasing at home. So if a behavioral health specialist does an assessment on the scene, we knew these calls would take longer. They were averaging about an hour to hour 45 minutes. So we know, because they're doing full assessments on scene, we know and understand that those are not quick calls. But what they save, even if on scene 2 hours, a transport and a bed in the ER that can be used by someone that absolutely needs the ER bed. So we are looking at all of this now. We're happy that Access is on board with us. And so we are, like I said, we extended our ET3 model. Another reason was, right now our behavioral health is strictly peak hours. So we have them 12 hours a day. On the ET3 model, it needs to be 24. You have to have 24/7 access. We do have a facility that's 24/7 for behavioral health now, but we'll have to get our unit up and running for 24 hours a day on that model. So anyway, this is where we are today. I think the behavioral program really is best for the behavioral patients. And if we can get 60 to 70% cost recovery on the program, I think that cities would be more apt to support it to make it sustainable, so we can continue with these programs for our communities. So in Mesa, this is what was working for us. And I believe that we're still going to continue moving forward with behavioral health. And then eventually in our ET3 model, we also wrote in that a year later, we would start to try and institute the nurse practitioner back into the system, just because it helps with those low acuity type calls. And if we can manage the low acuity calls a different way, alternate destination for behavioral health, I think it helps the healthcare system as a whole. And that's all I have.
Thanks, Chief. Great insight. And I think some of at least a key point that you hit on that resonated with me was, you identified where the problem was, where the call volume was showing the issue to be, and how the impact downward was going to be on the hospital system, and identifying that 10% are behavioral health emergency oriented or crisis oriented, some sort. Therein lies at least the start of your answer. It doesn't mean that every single patient with small ailments needs to go to different urgent care facilities or alternative transport locations, but identifying that a significant portion of the population, this particular social determinant of health, it was an issue, or is an issue, that you could at least start the impact there. That I think is a big part of it, and helps to create a starting point. So kudos to you guys for what you've done with that program, and certainly appreciate your insight.
Okay, thank you.
I see a question or comment here related to hospital systems that have, are a parent to urgent care facilities, and the hospital system is saying, we don't want you to go to the urgent care facility. What do we do with that? How do we combat that? How do we try to fix that? And you know what? Maybe, and I'm looking at this just, without a full context and just purely objectively, but maybe the problem's already fixed for you, or the solution is already there. Maybe this just isn't going to work for them for a number of reasons. I think asking the reason why would be appropriate. If it's purely money related, not much we can do there. But if maybe their urgent care centers are just not structurally fit for these types of patients, they really are built around the appointment-based modeling system and can't handle, the immediate walk-in appointments, which essentially we will be doing. If they're not built to be able to handle that, they don't have the staffing for it, they don't have the other resources for it, then maybe that's the reasoning. They just are not the right resource because of this. And therefore, they don't want to participate in these types of systems or these types of programs. And you know what? That's okay. They have that right. And I think that is fine. But figuring out the reasoning, asking, don't, not just accepting no, but asking why, I think is an appropriate course of action to go with that. So moving into, are we solving a problem or are we just moving patients? That I think is the third consideration that we need to look at. So again, we have a problem that results in a solution. And like Chief Kamali pointed out, what is the problem? Well, for them, it was behavioral health. That was a significant percentage of their call volume. So how can they affect that? How can they impact that and make a difference? And for them, it resulted in a solution to reduce overcrowding in their ERs. They've got an abundance of system, or at least abundance of emergency departments there. So the number of ERs wasn't the issue, but the long-term effect of the ER was the issue. And so at least identifying that social determinant of health, that particular call volume number, that metric, helped to build the pace for where they needed to go. Or vice versa. Is this a solution that's in search of a problem? Is there a problem for you, quite honestly? Is there really a need to transport somewhere else besides the ER? And again, are you really fulfilling the solution by doing this? Or are there no other local opportunities besides in ER? And this may pertain more to those further suburban or even rural areas where, again, you might have an urgent care clinic or a smaller facility that can handle some of these patients. In your emergency department is going to be a 20-minute drive. This may be a perfect solution for you to help turn around, your resources quicker and make them, more readily available. So, will transporting these patients to an alternative destination create more hardship? Are you creating more cracks in the system if you are indeed transporting them to these locations or pushing for that? And again, if the hospital system or if the parent system, the healthcare system itself isn't advocating for it because they don't feel they can handle it, then there you go. I mean, they're not ready for it. And, part of that might be just because of the staffing crisis that's going on now. I'm sure all of that's throwing a wrench in this. But if they haven't built that facility, haven't built its operations to handle patients like this, then there's really nothing we can do about that. So, with treating, transporting patients to alternative destinations, I think one of the fears that a lot of us have, and it's a valid fear, I think, is are we treating this somewhat like an MCI, where we are then, we're now taking patients, bunches of patients, hundreds, thousands of patients, and moving them to a different location where we're just simply moving the MCI from one spot to the next and just moving the patients around, dispersing them, rather than getting them to the definitive right place to start. So that, I think, is a valid question to look at. And certainly if you have a program running and you're finding that you are encountering a lot of issues where you bring the patient to an urgent care center, let's say, and then 30 minutes later you're getting that phone call or that dispatch to bring this patient now to a hospital. If this is a regular occurrence for you, then I think that this is a valid concern or valid consideration you need to look at. Is are you just exacerbating the MCI by just moving it to another location? So QA on the back end is going to be vitally important to make sure that whatever process, whatever screening tools you're using to look at these patients is valid and is fluid. It's something that is dynamic, can be changed and adjusted based off your data. Now, one of my concerns, and this is kind of a conspiracy theory or something, but a concern I have is, are we opening up Pandora's box by looking at transporting patients to someplace not an emergency department, not a hospital? And, I say maybe let's stick with emergency department because freestanding EVs, some of them can be very, very capable. But are we opening up Pandora's box by saying that if we're going to be bringing patients to places other than an ER, are we now putting ourselves at kind of risk where, we've already been through some of this kind of Uber, Lyft, uptick, and I think it's kind of waned down, but it may wax back up. What does it look like where, if these patients don't need to go to an ER, I would argue they don't need an ambulance. Therefore, can they go in a fire apparatus? Can they go in a patrol car or a secondary SUV vehicle, anything that is not an ambulance, licensed, labeled as an ambulance? Can they go in anything else beside that? How does that work? What does the billing look like? Your insurance, your liability, is that right? And what does the patient think about it too? Not that I'm all about patient perception, but we have to address what that might look like for them and set them up so that they are aware that an ambulance may not happen. So what does this happen here for us? And are there legislative things that need to be changed with your state EMS or administrative codes? I think there's a trickle-down effect of things that need to be looked at. Again, I think the end result, whether you are going to be engaging in alternative transport destinations or not, it's going to come down to prove it. Show your communities, show your stakeholders, your payers the proof. And if you are not having some sort of tracking mechanism, having the data, something on paper tangible to show them that this is beneficial, this is why you're doing it, or this is not beneficial, this is why you aren't, and this is why you can't, this is why you shouldn't do it, prove it. And if you can't do that, then you really need to take a step back and examine, evaluate, how can we prove what we're doing or what we are not doing. And again, if you're not doing it, that may be the best answer for you. And that may be entirely okay. Prove it though. So, it's all in the numbers. And I think that being transparent here is an important part. So do you share your data with your stakeholders? Are they asking about EP3? Are some of the elected officials that you have, somewhat cognizant of this happening in the industry? Are they aware of it? Are they not? Do you proactively talk about it so that they're at least aware? You make them aware. You set the stage for the conversation and say why you're not doing this or why you want to examine it. Annual reporting, I think, can be a great way of sharing information on a regular basis in a consumable format that shows, what the trends are. Build the case 3 years ago, to show that, behavioral health is becoming an issue and it's growing. And this year it grew. Last year it grew. The year before that, it kept on growing to where we are now. To we need to finally do something about these patients. We can't bring them to the hospital because it's full. But here's an alternative. And so if you are already doing this with annual reporting, wonderful. If you're not, I would really encourage you to set the stage. Your annual report is such a vitally important document, I think, because it sets the stage for what you want to do in the future. It's like strategic planning. What do you want to do in the future? You're just making this in a consumable format for others to read and take in and start setting the stage for why you need that budget increase, why you need the new apparatus, or why you need to increase staffing, or why you need to transport patients elsewhere, or maybe why you don't, why it's not so much an issue for you. So, do you keep your boss, the mayor, city managers, village presidents, whatever that might be, apprised of what's going on in the industry? I think it is better, and it's better in our favor, more in our favor, to set the stage of the conversation. They should hear about this stuff from you first and not from the news. So be informative and conversing with them proactively. And there we have it. So again, alternative transport destinations may just be a great thing for our industry. They may be the solution, to help a lot of the problems that we have. But having said that, they may be the solution for someone else, maybe not for you. And that's okay. The key thing is, though, is that if this is a solution or if this is not the solution for you, you've got to be able to justify that. Document it, prove it, show why, speak intelligently to it as to why you are engaging in this program or why you are not. And it's okay. But again, have some proof. So thank you again so much for attending. Again, Chief Gamelli, thanks so much for jumping in as well. I'm certainly glad to entertain any questions that you might have in the QA or the chat box, or reaching out to me directly, tnowak@tcgus.com. Finding me online, I'm on LinkedIn, all over the place as well too. So glad to engage in conversation with this, and thanks again to the IAFC for allowing us to have this presentation.
So there is another question in the question box, Tim, that refers to some of the regulatory or statutory authorities or ability to transport or not to transport to an emergency department. What do you want to comment on that a little bit?
Yeah, I'm trying to get through this question here quick. Or is it? Okay, in the chat.
And I think a lot of that is state by state, really.
Yeah, I would agree. State by state or sometimes county by county. Um, freestanding ERs can be tricky, and they can be kind of that initial triaging point. Certainly you've got to have a good conversation, a good dialogue with your medical director and them conversing with the facilities to make sure that you have both a direct path and a diverting path. Either direct path to freestandings or a diverting path around them. And, the more that you can, for one, I think your crews need to understand what can this facility do so that they can better understand what types of patients may go there. And from there, making sure that, again, you can put something on paper, some sort of flow chart of sort for what is appropriate to go to these locations and what is not. So yeah, every state, I agree, is going to be a little bit different with how they handle these. But involving your medical director in that conversation, so that they really have a one-on-one talk with those facilities is going to be the key starting point.
Another question for Chief Camelli is, I think a number of us on the call have experienced some reluctance from the part of other payers to participate in treat on scene or alternative destination. And you mentioned that Access came on board, which helps bring you close to what you need to recover the costs of your behavioral program. Do you, predicting the future, would you say that it sounds like commercial insurers will follow suit with that? What's your gut feeling?
Thanks for the question, Mike. Yes, I mean, that's our goal. Well, we were really, because we had been working with Access during our grant time, so they kind of were aware of our program. But after ET3 came about and then we reconvened, we were very happy that Access jumped on board. Our goal is that hopefully as we continue to do these programs and start billing for them, that commercial will come on board. We have reached out to a couple of other commercial insurers to tell them about the program. They were excited about it before, but now knowing that Access and at least Medicare fee-for-service is on board, I think that might be something that really helps to move it forward.
Great. One question came up in the Q&A, and I guess this could be for either of you. What would you suggest would be some of the first steps for an EMS agency who's interested in an alternative destination protocol to jump into that?
Yeah.
Yeah, I think a starting point is again going back to, is this do you have a problem that you need a solution for, or is this a solution that is in search of a problem? So do you really have an issue? Chief Camelli realized that there's like 10%, like a huge number, that these patients didn't need to go, and there was a significant impact on the hospital side. So is this really an issue? If you were a single station, 2,000 call a year department and an 80% transport rate, and that kind of demographic and deal, is this something that is even feasible for you to consider? I don't want to tell you yes or no, but probably not. But if you are a larger system and have these resources available and have these resources close by and can do it, that may be a different story. So I think the physical geography of where are you and where are these resources is probably one of that. Do you even have these resources available? But then two, do you have a problem? Or is this not really a problem that needs to be fixed? It may be a great idea, but will it create more issue, heartache, workload, burden by doing this? Do we have to be the solution to it? And we may not be the right answer for it. We, the EMS.
if I could add to something Tim said briefly, is just to Tim's point, any data that you have that tells your story, and also partnerships. We partnered with a hospital. They were more apt to come on board because they were part of the solution too. So if you have issues with low acuity calls, behavioral health, something that is your fire department is just getting bogged down with, that's kind of what was the catalyst for us. But also partnerships with hospitals or behavioral health facilities that might also help you move it forward.
Yeah, I would agree. If this is going to be if you are having to piecemeal it, where maybe this facility, maybe that facility, that's hard. But if you really have strong partnerships with the healthcare organization and can handle this, and they can provide you some behind the scenes support, even that is probably the key to it. Is find that right partnership that is going to best make this feasible and work.
Great. Well, thank you both for taking your time today to educate us. For folks who may have joined a little bit late, the handouts for this presentation, including the slide deck, are under the Handouts tab in the upper right-hand corner of your screen. Scroll down to the bottom and you'll see the actual slide deck that you can download, as well as some other helpful brochures and information from PCG. If you are interested in the polls, the results of the polls you can see by clicking on the polls box, and then once that screen comes up, pick on the closed polls and you'll actually see the results, which were pretty diverse from the group today, I think, across the spectrum. So we appreciate your taking time to join us. One item coming up this summer that was not listed on the upcoming events, probably because it's a little far in the future, is July 12th will be the virtual Fire Rescue Med Conference, which is an all-day conference. You can look for some more information about that through KnowledgeNet or through the IAFC webcasts, brochures, and website. So again, thank you to our presenters. And thank you to PCG for sponsoring this. Thank you to IFC for giving us the platform. And thanks to all of you for joining us today. We appreciate your attendance.